Hello.
Hi, how are you?
Good. How are you?
Good, thanks for having.
Oh yeah, yeah. So we'll give, it's not noon yet, and so like I said, we usually give people a few minutes to join even after.
Sure.
Do you have slides that you are going to
Uh,
or no?
yeah, I have like five or six on a PowerPoint here open. So I was going to do the screen sharing thing whenever I guess that comes online. It looks like right now I can't do that, maybe because the meeting's not officially started.
Oh, okay. I think Travis needs to make you the
Oh,
presenter.
yeah, I think he just did.
You just did, yeah.
Yep, I just sent it over.
Thank
Perfect. So
you.
do you see that little button to
Yeah,
share your
share
slides?
content. Yeah,
Um, and you say your first name Vivek or Vivek?
it's Vivek.
Vivek. Okay.
Yeah.
And are are you because I had tried to pull you up online. It looks like you're also affiliated with another practice, or is that just an old website?
No, so that the website that comes up right away, that's essentially my quote unquote practice. I'm part of Shannon's group officially, but I'm the only surgeon. So I sort of, have my own website and, that sort of stuff. But I
Okay.
am, basically their associate.
Oh, okay. I see.
Yeah.
Okay, because I thought I was like, well, maybe yeah, I didn't know if you had like a part two, part time sort of position.
Yeah. No, I used to be with Hopkins about 6 years ago. I left and then I joined Shannon's group and have just stayed with them since then.
Okay. Oh, perfect. Okay.
And how long have you been with Rockville?
Rafa, I've been here for 3 years.
Oh, great. That's nice.
Yeah. I know somebody the other day said, I saw a patient, he said, congratulations on joining the practice. And I and like scratched my head because I was like, look, I don't know. I mean, 3 years is a long time.
Yeah, that's not a new practice for
I
sure.
was like, I mean, I guess maybe in the scheme of things,
Yeah. In a
uh,
30-year career, I suppose it is new, but
I know. So you've been with them now 6 months?
no, 6 years.
6 years, sorry. Oh gosh. Oh
Yeah.
gosh. Okay. And then where do you operate out of?
Suburban and Shady Grove mostly, um, but very, very occasionally Holy Cross.
Okay.
Have you been doing a lot of telemedicine?
Yeah, we do. Yes, we've been since March. We have a rotation. We have two doctors in the office I guess every day. We have at least two
Mhm.
there. So we are, so, it's a big enough group that we are all there maybe about every other week. And then I think there's some murmuring sort of plans to open more in July,
Okay.
trying to figure out some of the logistics for that.
Yeah.
But and then I think what Shannon said was you guys, your lab is open and you're still doing some visits, but mostly virtual.
So I'm doing almost all in office now. I did virtual for a while, and but my obviously I need to do small procedures and exams and stuff like that. So I sort of need to be in the office, and people have been perfectly. I mean, I'm basically back at full capacity almost.
Yeah.
And it happened very quickly, like within 2 weeks. It was very slow for about 3 weeks, and then all of a sudden it was like back to normal.
Yeah. I mean, I think you're also in a uh, specialty medicine where not a lot of stuff can wait.
Yeah, yeah, essentially,
If
exactly.
somebody's in pain or bleeding, they don't want to wait,
Yeah,
a month to be seen.
exactly.
But yeah, and then and the hospitals you operate out of, are they um, are they like back at? I mean, are
Close.
they allowing you to do full capacity, or do they have all kinds of options?
Yeah, so most of what I do is actually in the office and then surgery center, which has been open for a while. Um, the hospitals is where I do, the major abdominal stuff, cancers and diverticulitis, and they are starting. They're basically within the next week or so should be sort of full capacity.
Okay. All right. Well, it looks like we have a little bit of a quorum here. I would say we have about 60 people who have joined our call today, and the number is going up. So for those of you guys who are tuned in, thank you. I am Dr. Tanno. I'm one of the family medicine physicians at Rockville Internal Medicine, and I'm sure most of you who have been watching these by now know me. I just actually looked at our webinars, and this is our 36th webinar. So that's crazy. So thank you to those of you who have tuned in. I hope you're enjoying them. Today we have a special treat. We have Dr. Vivek Patil from Maryland Oncology Hematology. So for those of you who tuned in last week and saw Dr. Shannon O'Connor talk about medical genetics or cancer of genetics, he is one of her partners. He's a colorectal surgeon. So very, very different from being an oncologist, but he can tell us, I'm sure, a little bit more about what exactly he does on a daily basis and a little bit of what a colorectal surgeon is and what kinds of patients they see. So like I said, he practices in Bethesda and Rockville. He did his medical training at Georgetown University, and then he did 6 years of surgical training after medical school. So to become a surgeon is a long route, as many of you guys have probably figured out by now, but you do 4 years of medical school and then you do a surgical residency. So his was 6 years of additional training past 4 years of medical school. He enjoys cooking, biking with his family, and boxing. So you'll have to, before we actually can talk about anything colorectal, you'll have to tell us about, you have to tell us about the boxing. What's the backstory there? How do you do that?
So the boxing is, I joined one of those, the sort of freestanding boxing gyms some time ago, mostly because I heard it was a good workout, and have really sort of fallen in love with it as a sport, and kind of gotten into the point where I have, I spar as well. So it's an incredible workout. It's like a really good, both mental and physical. It seems like, two people just, beating the heck out of each other, but it really is more scientific than that.
Wow. And so how many days a week do you do the practices?
Well, pre-COVID, I would say I was going 4 to 5 times a week. Since then, it's been essentially zero. I've just been at home since the gyms haven't really been open. So I've been just sort of trying to do stuff at home, essentially.
And is sparring a official competition, or is it just two people?
It's two people essentially doing rounds of boxing each other. So it's it's not a competition per se. It's just sort of like, it's as if you were practicing with like tennis, for example. You're practicing tennis with a coach, and then you go and play games where it's competitive enough, but it's not, it's not high stakes. You're not, playing a tournament or something along those lines.
It's funny because Dr. O'Connor does the trapeze, so I guess practice, you have to do an out of the box physical activity to be a member of practice.
Yes.
Is what I'm learning.
Yeah.
All right, let me just say to everyone on the call, we have about 75 people, so I think we can go ahead and then let Dr. Patil get started. If you have questions along the way, you can submit them either to the chat or to the QA section. The chat, remember, is a little more public for everyone to see, whereas the QA only comes to the panelists, so only myself, Dr. Patil, and then Travis, who's our IT support on the call. So that's a little bit more private, and we can hold those questions. If something is very important and pertinent, I might ask in the middle of the talk. If not, we can just hold those till the end, but do submit questions. That's why we have these webinars, so they can be interactive as opposed to just recorded lectures. I think that's about it. So I'll let you get started, and I'll disappear off the screen so that I'm not distracting anyone, and then I'll come back as questions pop up. Sound good?
That's good. Yeah, thank you.
Go ahead and share your screen. Oh, somebody wants to know before you get started if you've ever been knocked out in boxing.
No, the stakes are not quite that high.
Okay. All right. All right, now we can get started.
My trainer is aware that I'm a surgeon, so there's no.
Yeah, guys, he has to protect that noggin. It's worth.
I'm gonna, prior to sharing my screen, I'm just gonna, talk for a few minutes. As Dr. Tanno had said, my name is Vivek Patil. I'm a colorectal surgeon, and I practice in Rockville and Bethesda. What a colorectal surgeon is basically an abdominal surgeon, meaning that we do surgery of the gastrointestinal tract. So after you finish medical school for 4 years, you do 5 years of something called general surgery, which is surgery of disorders of the gastrointestinal tract. And then you do an extra year after that to total 6 years, focusing on the lower GI tract, essentially, and all the disorders that come with that. So those include both benign things, which we're mostly going to talk about today, as well as malignant disorders such as cancers, and you're probably familiar with those. So today's discussion is a talk about things we don't talk about, namely conditions of the lower GI tract that are common and really can affect anyone, but we don't really mention in polite company. And we're briefly going to go over some abdominal conditions that I had mentioned earlier, dealing with the lower GI tract, but really going to focus on the benign stuff that's a little more common. We're going to talk about some prevention as well as treatment if you were to develop these conditions. So, a discussion about surgical stuff always should start with some anatomy. So I'm going to try to see if I can share my screen here. Can everybody see that? I'm assuming everyone can see.
Yeah, we can see the.
Okay, great. So this is a small schematic of the GI tract. This is a person standing in front of you. Right here is the rib cage where the lungs are, and just underneath that, and separated by a muscle called the diaphragm, is the abdomen or abdominal cavity. So as you're probably aware, the GI tract starts at the mouth, and you have the esophagus, which comes down through the center of the chest here, and then that becomes the stomach. And after the stomach, it transitions into the small intestine, which is this very curly, coiled up organ, extremely long. And the reason it's so long is it basically needs a lot of surface area for digesting your food. So all the nutrients are extracted from the food as it comes through the GI tract, through the small intestine. Once it gets over to the right side of the abdomen, you have the colon. And the colon is also called the large intestine. You can see here it sort of frames the abdomen like a picture frame. It is about 4 to 5 feet-ish in length, and its job is to reabsorb water from what you've eaten, some nutrients, and it also hosts most of our gastrointestinal, sort of quote-unquote good bacteria. The last foot of that colon or large intestine is called the rectum. So everybody thinks of the rectum as the anus, but there's really a distinction, as the rectum is about a foot long and it's in your pelvis. As the large intestine goes into the pelvis, it becomes the rectum. It's about a foot long. The last 2 to 3 inches of that is called the anus. And that, so you can see here, this is the right side of the colon. This is what's called the transverse colon, descending colon, and then here's the rectum here. And the last little 2 to 3 inches is called the anus. We have all these distinctions in terms of names and locations, but it's really one long organ. Obviously it's amazing how much problem can arise just from that last 2 to 3 inches, and that's, mainly what we're going to talk about today. So the common complaints as when people develop problems in that area are really 3 main ones. I have pain, I have bleeding, or I have swelling. the reason I wanted to do this talk too is because most of the time when people do feel those symptoms, they assume that they have hemorrhoids. And so they say, you know, I have hemorrhoids and I have these symptoms. But it's not always that. You know, there are other conditions that can occur in that area that are not hemorrhoids. And so that's what we'll touch on. So as we go a little bit further into the anatomy, this is the rectum here, this like foot-long thing here. This is hard to sort of understand what this is, but this is essentially if you were slicing someone in half, you're looking directly at the back half of them, and this is the muscle of the pelvic floor. This would be sort of a circle around the area. This is called the pelvic floor muscle. And this little area right here is the anus, that last 2 to 3 inches. So you can see there's a lot of, even though it's very, very small, there's a lot of anatomy. The main part of the anatomy here is also in a circle, is what's called the sphincter muscle. And that's the muscle that's responsible for control of your bowel movements. And so that's the function of that last 2 to 3 inches, essentially. There's also immune tissue there, which is its other function. So these are, you know, when people have, again, symptoms, a lot of it is pain, bleeding, or swelling. So the first thing we're going to talk about are hemorrhoids, since that's the most common condition, as well as complaint that people have or feel that they might have. So the anatomy of the hemorrhoids are that they are the end veins of the anal canal. So they're actually normal structures. You're born with them. They're simply the end, the last little tiny bits of the veins that course through the rectum. And so there's actually 3 of them, 2 on the right side and 1 on the left side. Also, on the skin surrounding the anal canal on the outside are these tiny little microscopic sort of veins underneath the skin. And so, again, these are all normal structures, but they can get inflamed, and when they do, they can cause symptoms. So on the acute end of symptoms are these external hemorrhoids here. So the reason we call them external is because they're obviously outside of the anal canal. And what happens with them is that you get what's called a thrombosis, which is a little blood clot that forms suddenly within the hemorrhoid underneath the skin there. And that you feel as a lump. It's tender, and it happens sort of all of a sudden. As far as the internal hemorrhoids go, which are inside of the rectum, now those are the ones that are 2 on the right side and 1 on the left side. Those are more of chronic condition. They don't usually happen suddenly. They happen over time, where you'll start noticing that you may have some painless bleeding, which is the classic symptom. So you get some bright red bleeding, usually not dark. And it often, you know, you'll notice it when you're going to the bathroom. So you will say, wow, that's a very new and unusual thing, where I go to the bathroom and I'm noticing some blood falling out. Sometimes when they get to a certain size, they actually start to protrude out of the rectum. And you'll perceive that as a swelling. And after a while, if they get even sort of larger, they will sort of persistently, a portion of them will remain outside. And you'll sort of feel them all the time. And so that's the progression of sort of mild to moderate symptoms as it comes to hemorrhoids. And we'll talk about why they happen and why they get inflamed in some people and not others. But the next thing I'm going to touch on is something called an anal fissure, which is a different condition from hemorrhoids. So again, this is that sort of cross section, a little bit blurry, I'm sorry. But this is the anal canal, that last 4 centimeters. This is sort of a circle right here of the sphincter muscle. And this right here is basically a crack in the skin or a tear. It starts just at the edge, like on the outside, and it may extend a bit inside, maybe a quarter inch or a half inch into the anal canal. That is just like the external hemorrhoids we talk about. That usually is an acute problem that happens. And what happens is you get like a cut. So you have a sudden break in the skin after a difficult bowel movement, whether that's constipation or sometimes diarrhea. It breaks the skin and it really, really hurts right away. And you know, oftentimes people think that something is terribly wrong because the pain can be quite severe. What happens also is this sphincter muscle here goes into spasm as a reflex, and that contributes to the pain. So what happens is that you get this acute pain and sort of persists, and then it may calm down after some time, but every time you go to the bathroom, you sort of re-aggravate the injury. Usually, luckily, that process will resolve within a few days or a week, but sometimes it can be chronic and really kind of continue to cause issues. So the next condition we'll talk about, or the third condition, is something called an abscess, which is also related to something called a fistula. So this is an unusual condition, but it does happen commonly. What happens is there are glands within the anal canal, and people with pets, or especially dogs, they may know about vets talking about expressing the anal glands of a dog. I don't have a dog, so I'm not sure about that particular thing, but that's what I've heard. Essentially, it's a similar process where you have these glands, which are just sort of normal structures, and they sporadically just get infected. And when they get infected, what happens is they will actually migrate outwards towards the skin. And once they migrate outwards, they will form this sort of boil underneath the skin. It looks and feels like a boil. It's swollen, it's painful, it's red, and at times you can get fevers. Those generally about 70% of the time will resolve either spontaneously, they will rupture, or they get treated by a surgeon. And 70% of the time they will just heal and go away. But 30% of the time, that migration area which is a tract, essentially a little tunnel, is called a fistula, and that may persist. And if that happens, basically the original infection resolves, but the person remains prone to having recurrent infections in that area. That's called a fistula. Lastly, in terms of conditions that are sort of concerning to people, these are the most common conditions that a colorectal surgeon would see sort of in the office as a routine. And these are, again, of course, benign conditions. But oftentimes people come in and they say, okay, I think I have hemorrhoids, but I want to make sure that I don't have anal cancer. People get concerned because some of the symptoms of anal cancer can be similar. Bleeding, swelling, pain, but this condition is exceedingly rare. What it is a malignant transformation, meaning a change from benign to cancerous, of growths around the anus due to the HPV virus. And the HPV virus you may or may not know about, but it's a very, very common condition in the United States. Most of the time, and the vast majority of people, very, very asymptomatic. It is about 80% of people in the United States have been affected at some point in their life. So it's extremely common. It is worldwide one of the main drivers of, or the main driver of cervical cancer. And those types of cell transformations are very similar around the anus. So it's sort of the same process. But out of the 80 million, or so people who are affected with the condition at any given time in the United States, only about 8,000 new cases of anal cancer occur in the United States every year. Most of the time in people who are immune suppressed or who have other conditions. So, and it's the incidence is so low that we don't really have any effective screening mechanism for it. And most of the time, people will just see it or sort of be screened for it, quote unquote, during the time of the colonoscopy. So all that is to say, it is very unlikely if you see blood that you will have cancer. Some of the abdominal conditions we take care of as colorectal surgeons are something called diverticulitis, which is a weakening of the colon wall that can happen. Some of it is genetic, some of it is aging. It has to do with really abnormal contractions of the colon. It forms sort of almost little bubbles off of the wall of the colon that have the potential to get infected in a condition called diverticulitis. You'll get abdominal pain, bloating, fever, nausea. And most of the time, this condition, it's not extremely common to get diverticulitis. Most of the time, if you do get it, you can get treated really with antibiotics. A small subset of patients may need surgery to remove a section of the colon, which is something that I do, but it's uncommon. Colon cancer is another thing that I take care of. Unfortunately, more common, and it's way more common than anal cancer. You probably know of it as colorectal cancer. It almost always requires surgery, as well as associated treatments like chemotherapy or radiation. But again, that's not really the focus of the discussion today. So the prevention, how do you prevent these conditions that we just talked about? Now, the common main risk factor for these conditions, certainly for the benign conditions, but even plays a role really in malignant conditions, are abnormal bowel movements. You have irregularity of the bowel movements, meaning constipation, diarrhea, and this, of course, has many causes in people. Poor diet, low exercise, stress, the GI tract is particularly sensitive to the outside environment. So all of these things can be additive factors. But really the biggest factor that you can sort of control is not getting enough fiber in your diet. What is,
sorry? I was just checking. I wanted to know if you had more slides. I wasn't sure if you had.
Yeah, I really, this is the sort of last slide. I don't have too many more slides.
No, I was just curious because you were talking about other things and I wanted to make sure that you weren't
missing out on the slide. Yeah, images, I couldn't find good representations of the other processes we talked about, so I kind of left out the slides. What is fiber? Fiber is plant-based food that's not digested and passes through your GI system. It basically helps to regulate the consistency of the bowel movements. It normalizes the contraction, so the intestinal tract doesn't have to work as hard to pass the food products through. It also has other benefits, lowering cholesterol, your blood sugar, hypertension. So overall, it's a very good, essentially, dietary product that you should be consuming on a daily basis. The standard thought is probably about 25 to 30 grams fiber a day. It's not easy to sort of calculate exactly how much that is. But what you want to do is really increase the fruits, the raw fruits, raw vegetables, whole grains in your diet. And at sometimes people also use supplements like a Metamucil or Benefiber, something you can buy over the counter. But it is always best, of course, if you can get it from dietary sources. The internet obviously is a very large repository of information for that. And even to the point of telling you how much fiber is in each thing. So if you really wanted to kind of be precise about it, you certainly could. Coupling an increase in fiber with increased water intake, exercise, good sleep. These things are always very helpful and will help regulate the GI tract. Also, don't bring your phone into the bathroom. That's a very good piece of information as well, because you end up spending more time in there than necessary. So basically, if you notice occasional pain, spotting of blood, some swelling, the first thing we always recommend as physicians is to increase your fiber, your water, and do all those sort of things I talked about, exercise. If these symptoms were to persist or certainly become severe, the best thing would be to be evaluated in the office by a physician. Good place to start, of course, is your primary care physician or gastroenterologist. And they will refer you to a surgeon, a colorectal surgeon, if they feel it's necessary. Sometimes people come to see me without being referred, but most of the time, people have been evaluated prior to that. When I see patients in the office for these conditions, first thing I do is really discuss their symptoms very thoroughly, because a history will often make the diagnosis. As we talked about earlier, hemorrhoids, you're going to get often painless bleeding. Fissure is going to be severe pain after bowel movements, not so much in the way of bleeding. So, you really got to kind of parse out as the surgeon what's going on, because you really want to make sure you're treating the appropriate thing. Once the history is made, then we obviously examine the area to make sure that we're either confirming the diagnosis or or figuring out what else it could be. So as far as treatments go, again, we talked about prevention. So how do we, prevent these things from happening? But unfortunately, if you were to develop it, then there are, of course, treatments for these conditions. So for hemorrhoids, as I mentioned, mild symptoms can be treated really with the conservative management, increase in fiber and water. And most of the time, for mild, very intermittent, painless bleeding, this will resolve. I, still examine the people in my office to make sure that nothing else is going on, but that's usually what we recommend. When the symptoms are more severe, then we move on to other treatments. So, for example, for external hemorrhoids, that's the acute swelling that you get, and that was the sort of the external thrombus, as we call it, or thrombosis with the blood clot in it. This often is, change your diet. This can happen because of the irregularity of bowel movement, but other types of pressure as well. For example, if somebody is on a long plane flight, it can happen. Pregnancy can exacerbate this condition. But we usually give reassurance and say, with a change in your diet, some warm baths, and sometimes we employ some topical treatment like a topical steroid, but this will usually resolve within 72 hours or so, sometimes up to a week, but it usually gets better on its own. There are times when people have severe pain from this, that they can't function properly, or it hasn't resolved within a week, or it's bleeding significantly. And I will often just excise that in the office, meaning inject the area with a little bit of local, like a Novocaine type thing, and just remove the blood clot, and people do very well with that. For internal hemorrhoids, if the conservative treatment doesn't work, then we usually do office-based treatment for that. And the most commonly used treatment is something called rubber banding, which sounds frankly crazy, but it actually works. Basically, the idea is that it's a 30-second procedure where you would put a small rubber band around this area of the hemorrhoid here. And what that does is it essentially cuts off the blood supply to the rest of that portion of the hemorrhoid, and it sort of shrivels up, and the band and that portion of the hemorrhoid will fall off in about 2 or 3 days when you go to the bathroom. 30-second procedure, most people have no pain from it. Very, very low risk procedure, and can be extremely effective. This, I would say, is the majority of the way that both the conservative treatment and the rubber banding is how I treat probably 95% of patients with hemorrhoids. The other 5% of the patients, they either the banding doesn't succeed, or they can't have banding because their hemorrhoids are too advanced. And those people will need surgery. And surgery is a very also safe procedure. It's done as an outpatient in surgery center. It's about 30 minutes in length. And essentially you remove the hemorrhoids. And again, generally 3 of them, 2 on the right and 1 on the left. That procedure, very safe, but the recovery is painful for about a week. So people try to avoid it. Obviously, I try to avoid it in patients if I can. The positive is that if you did have to have surgery, then you are sort of done with the hemorrhoids. They've been removed, so that's, kind of that's that. So, as far as hemorrhoid treatment goes, there's a couple, the 2 myths I like to break about hemorrhoids is number 1, that you can't do anything about them and you have to live with them because there's no really good treatment for it. So that's, I believe, is false. And then the other myth that people say is never do surgery for it because you are going to get incontinent. You're not going to have any control of your bowel movements. And that is also patently false, especially if it's done by a colorectal surgeon who, obviously we know the anatomy of the area. So I guess the take-home point as far as hemorrhoids is don't feel like you have to suffer through them if you're having a lot of symptoms, because there are things that can be done about them and that they're very effective. As far as the anal fissure treatment, same thing. The mechanism of this is as we talked about, increase in pressure from irregular bowel movements, straining, spending too much time in the bathroom. So always start, if this happens acutely, with fiber, warm baths, sometimes topical treatment as well with steroids. There's some special anti-fissure ointments, which basically, as we had mentioned, this circular sphincter muscle goes into spasm because of the pain, and that compounds the pain and also helps sort of delay the healing. So there's a special and some anti-fissure creams which actually relax this muscle, and that helps that fissure heal. So sometimes we use those. It's rare, but sometimes these fissures can become chronic, as we had talked about, and they just stick around for a long time. In that case, sometimes you need secondary surgery for that. Again, a small procedure. Lastly, I'll just talk about for the abscess. An abscess is usually more of an urgent thing when that happens because the infection can spread. So I will often drain this in the office. So again, inject the area with a little numbing Novocaine, and I'll make a little incision there to drain out the infection. That helps treat the acute infection and prevent the fistula formation, that tract that remains persistent 30% of the time. If the fistula is there, then unfortunately that does not heal by itself, and that is something that needs surgical correction as well. I got a quick question here. Somebody had asked about they had banding about 30 years ago, and would they need repeat banding? And really, it depends on the symptoms. So treatment of hemorrhoids is really treatment of the symptoms, again, of the irregular bowel movement. So if you don't have any symptoms, then you don't need treatment. And treating the hemorrhoids also doesn't take away the underlying condition, which is that irregularity. So you really have to couple the increasing in fiber, making sure your bowel movements are normal, and starting there. And if that's that's already done and you're doing a good job with that and you still have symptoms of bleeding and swelling, then yes, perhaps banding would be a good option to kind of treat them again and get you back to more normal condition. So that's kind of quick run through of everything, and
yeah, I think you did a really nice job making things, well, especially with the pictures of the anatomy, I think making things clear, what is a fissure, what is a hemorrhoid. Also reassuring people that not all bleeding is anal cancer, even though everyone always gets scared. So we have a lot of questions here. I think people are curious. This, like you said, these are things people don't like to talk about, but they have a lot of questions. So you had recently, you just said a question about banding, but this is maybe a little similar one. Hemorrhoids banded 3 times. I've had my hemorrhoids banded 3 times, but they still come back. When do you decide to do surgery, and then what does it entail? And I know you had touched a little bit on surgery, but maybe just give a little recap for the questioner.
Sure. So I'm sorry. What was the question again that you wanted?
Oh, sorry. I've had my hemorrhoids banded 3 times, but they come back. When is surgery warranted?
Okay, so I see. Having a banding multiple times that doesn't work, then often we do move to surgery next, because usually what that means is that the hemorrhoids are a little bit too advanced to sort of be successfully banded. So surgery is an outpatient procedure. It's done at a surgery center. Similar anesthesia to a colonoscopy, a sort of IV anesthetic. You fall asleep for about 20 minutes or half an hour. The hemorrhoids are removed, and then you wake up and you go home. It's a very, very low risk procedure in terms of infection or bleeding in the immediate period, and in the long-term period, essentially almost no long-term complications. And that's what I was mentioning before, where people, even some older physicians will say, I would never get surgery. I would never recommend surgery because you'll automatically be incontinent, and that's just not true. So once you get through the week of pretty significant pain, because obviously it's a quite sensitive area, then generally you resolve, and that's that as far as your hemorrhoids go. So that's, it's possible that that one would need surgery, but really probably should be evaluated by a colorectal surgeon to make sure.
Yeah. And then here's another question. If I occasionally see blood on the toilet paper, should I come see you or go to my gastro doc first?
I think either or. I don't think there's usually if you see a gastroenterologist, then they can make the decision whether or not a surgeon is needed. If you see a surgeon, then they can obviously make that decision, whether you need treatment. So I think it's equivalent in both situations. I think it would be fine to do either.
I just have a question. Are there any situations where a colorectal surgeon does the colonoscopy instead of a gastro? Does a screening colonoscopy? Are there any scenarios where you might send somebody to you over a gastro?
Sure. So I do get some referrals for screening colonoscopies. I don't know exactly what the thought process in that is. I certainly do them all the time, and I don't have any problem doing them. I'm very comfortable with it. I don't do a lot of them as compared to the gastroenterologist because they usually get the most of it. So I think it's, certain referring physicians just feel more comfortable with a surgeon doing it, I suppose. There are times when a gastroenterologist might send me someone to do a colonoscopy on if they found a condition or finding that they feel like they can't take care of, and I might need to redo a colonoscopy in order to visualize the area. Those are kind of the main reasons that I do a colonoscopy.
Okay. All right. Well, we are getting a lot of questions, so let's try to zip through as many as we can.
Mm-hmm.
So I've heard of people getting colon cancer in the large intestine. Is it possible for one to get cancer of the small intestine, and how common is that?
It's very, very uncommon, extremely uncommon. There isn't an effective screening tool for that. Basically, what would happen is somebody would, probably demonstrate bleeding or pain and get an evaluation, with different things, a CT scan, blood testing, colonoscopy, endoscopy, and eventually get to a point where they say, okay, we can't find the source. And then they may do some testing of the small intestine and find it that way, but it's very, very uncommon.
Okay, so can you address conditions that cause periodic itching in the anal area? I have an itchy bump at the entrance to the anus.
So that, sometimes people get itching from like a fungal infection, like a yeast infection type of situation. And that needs to be treated with some topical ointments. An itchy bump could be sometimes a chronic fissure that can cause itching, as we talked about, that break in the skin. When an anal fissure is acute, it's super, super painful, but as it becomes chronic, it becomes less painful and more just sort of annoying. And sometimes itching, occasional spotting of blood becomes the really prevalent symptoms. So that it probably needs to be looked at, essentially.
Yeah, I think any bump, anything that you think feels weird should be looked at by somebody.
Yeah, agreed.
And then, does Desitin work on hemorrhoids?
It can. It not really on hemorrhoids per se. If you have some irritation or soreness in the area, and it's something that happened recently, and it just sort of sticking around a little bit, certainly Desitin is perfectly fine. It's skin protectant essentially, especially in the summertime. Obviously, that area can become very sweaty, and that's how people can get these fungal infections and irritation. So if that seems to be happening, a little bit of mild irritation, Desitin is perfectly fine. If it persists, then get it looked
at. So this person didn't phrase this as a question, but if I were to put it in a question, I think it is, what is the effect of blood thinners on hemorrhoids?
Blood thinners can very much exacerbate bleeding from hemorrhoids. I see it all the time. And it's, of course, a trickier situation because you have to figure out, can we hold the blood thinners while we're treating the person? Do the blood thinners need to be there for a long period of time? Should we wait until they stop the blood thinners? Is it lifelong? So it's kind of a little bit more of a challenging treatment, but if they're not causing excessive bleeding, then they have no direct effect on the hemorrhoids. But if hemorrhoids are bleeding, then it can certainly exacerbate
them. And how do you feel about taking probiotics? Are those helpful for any of these conditions?
Probiotics are certainly very helpful. It depends on the person. The studies are still kind of not definitive as to who should take them, for what conditions, how long, what types. Those are all kind of questions that need to be answered over time. But certainly they're not harmful, and they have shown to have beneficial effects in GI conditions, and even in people without GI conditions, and regulating your bowel movements.
I like this question. I don't know why. It says, what is the purpose of hemorrhoids? Do they serve a function?
Sure.
You get the little hemorrhoids, like going to school and trying to find a purpose in society.
Yeah, exactly. So nobody knows for sure. They are the end veins. So they're just sort of like the endings of the veins. They just happen to end right there. But they do play apparently some role in continence, a very, very small role, meaning that they kind of just mechanically sort of a little bit block the area. So if it's such a small role that if one were to be relying on the hemorrhoids for continence, then that probably means they're in pretty dire situation in terms of the the strength of their sphincter muscle. So in the, vast majority of people who are young and healthy, if you have your hemorrhoids removed, it has zero perceptible difference in continence.
I had hemorrhoids treated in the past via cauterization. Is this no longer a advisable treatment?
There were different ways of cauterizing them in the past. Now, really, they use something called infrared coagulation, which is an office-based procedure where they sort of it's like an infrared beam that essentially heats up the hemorrhoids and kind of cauterizes them a little bit that way. I don't use it. I've used it in the past. I've sort of it takes a lot more applications than banding, and it can be more uncomfortable. So I didn't find it. I found it to be inferior to banding, so I don't necessarily do it. Some people still use it. There's nothing wrong with it. I just don't elect. I don't feel like it's a good treatment option for me.
And then we hear about the pain of hemorrhoid surgery. I know you had mentioned that it's generally well tolerated, but maybe speak to some of the counseling you give to patients who are thinking about doing hemorrhoid surgery after surgery, what they should expect.
I mean, I tell people, expect a week of pretty significant pain and just go ahead and write that week off in terms of work or, leisure activities. So when you get home, I mean, you're functional, you're eating, you're walking around, you're doing normal things. It's just that like the first 2 to 3 days are pretty consistently sore. And, I do give you pain medicine to help you get through that. After that, you start to feel better in general, but every time you go to the bathroom, it sort of, it kicks up the pain. Once you're getting to day 5, day 6 after surgery, then you're starting to feel better. You certainly don't feel 100%, probably for about 2 weeks in total, but after those first 5 to 7 days, you're saying, okay, now I'm kind of back in the swing of things more. So that's kind of how the arc of it goes.
And then some people here are interested in scheduling an appointment with you. I want to remind you guys that Dr. Patil is not a doctor at Rockville Internal Medicine. He is with Maryland Oncology, Hematology. So if you call our office, they probably won't know what you're talking about. But so Maryland Hematology Oncology, I put their name in the link that you guys got sent out to you, but if you Google his name or you Google that practice, you can find their contact information. And then Dr. O'Connor is here on Wednesday. They practice out of the same practice, so it's the same location. She had posted some addresses last week.
So yeah, it's my email. I mean, my website is just my first and last name, md.com. So Vivek Patil, md.com. Easy enough to remember.
His name was it's emailed out. It's on our website. So you guys, if you want to check the spelling or something later, it's there. All right, and then let's see. There's a lot of questions here, so let me just pick out maybe some that I think are most pertinent to the vast majority of people. And then if you have further questions to anyone, if we didn't get to your question today, I do apologize. We have about 30 questions here. We just can't do them all. If you have questions, feel free to schedule a virtual visit with one of your primary care doctors, and then we can steer you. Is this something that we treat? Is this something that one of our gastros treat? Is this something that you need to see a colorectal surgeon for? But that's where I recommend, especially if you have a specific situation that you've written in about, a past history. It's always good to talk to somebody who can get all the details. So maybe time here for 2 questions or so, but does preparation H really work?
Yes, it can work for acute swelling. It's not a long-term treatment. Even topical steroids, which are stronger anti-inflammatory treatments, they're not for long-term sort of quote-unquote hemorrhoid cure. They're basically something's happening down there, it's inflamed, and it's uncomfortable. You apply the anti-inflammatory, whether that's preparation H or steroids, and it gets better. That's just sort of taking care of the acute issue, but really the underlying problem needs to be looked at, whether that's simply adding fiber and exercise and so forth to your diet, or whether you need something like rubber banding.
All right, and then last question that I think we're gonna have time for today. Can you talk about some of the creams that are prescribed for anal fissures?
Sure. So I often start with topical steroids, something called fluticasone, and that can be helpful in very acute, very sort of superficial fissures. But if I feel like they have that muscle spasm component to it, then there's a couple of smooth muscle relaxant creams, which are actually compounded. So you have to get them compounded in a special compound pharmacy. You can't pick them up at the CVS. And those usually the main ingredient of that is actually a blood pressure medication, something called diltiazem or nifedipine. And those are smooth muscle relaxants. They compound it into a cream, and you use those about 2 to 3 times a day for a couple of weeks, and that can be helpful. With chronic fissures, unfortunately, medical management is only helpful about 60 to 70% of the time. With acute fissures, they get better almost always on their own.
All right. Well, thank you so much. I think that was great to hear all those topics. I'm sure some of us got some private questions answered there, so that's always good. So thank you so much for coming. And for those of you guys, if you guys are interested in scheduling an appointment with Dr. Patil, I would recommend, he had said his website, but also his name and spelling came out with the email, so you can always find him that way. If you have any questions, you can ask send your message to your primary care doctor, and I'm sure they can figure out. You just say that you saw him in the webinar, and they'll look and see. But go ahead and if it's a new question, talk to your primary care doctor, and we can direct you on where to go, because like he said, not everything needs to go to a colorectal surgeon. A lot of things are handled by your primary care doctor or gastro. But thank you to everyone for joining us. Thank you to Dr. Patil for such a great,
thank you.
Very easy to understand, I think, and really explained well. So that's nice. And you can tell that you have a nice bedside manner. So for the
thank you.
Who were thinking the same thing, it's always nice to meet a surgeon who makes you feel comfortable. And then lastly, on Wednesday, we have a lecture from Dr. Kelly Cowan and Dr. Carter Holmes. They're going to talk about medical marijuana. Dr. Cowan has been doing medical marijuana consultations in her office, I think, for about a year. She can tell you more about that on Wednesday. But I'm sure there's a lot of curiosity and, who gets medical marijuana? Why do you get medical marijuana? So that'll be Wednesday's lecture. And then we do not have a lecture this week on Friday, just the 2 this week. So thank you to all of those who are joining. Thank you to Dr. Patil for such a wonderful talk. This is recorded and will be posted to YouTube. So if there's something that he said that you want to look at later, if you want to show all your friends everything you learned today, go ahead and send them the link to that. We have our YouTube channel, Rockville Internal Medicine group, where it gets posted a little bit on a delay, so give it a few days. But thank you to everyone, and I will see you guys on Wednesday. So thank you. And thank you for Dr. Patil.
Thank you, Dr. Tanno.